All right, everybody. Good evening. It's the last webinar. We're getting very close to the final here. It's 8 o'clock on the East Coast, 8:30 in Newfoundland. Time to get started with Rehabilitation and Anatomy. We have two excellent speakers from the Miller Review course. Matt Schmidt's going to start us off. He's a major in the U.S. Air Force. He's currently a pediatric orthopedic fellow in San Diego, and he'll be going to San Antonio next year, where he will be the chief of pediatric orthopedics of a very small band of Indians. Rehab and basic science are important talks. Rehab is really where you're going to be able to pick up those extra points that you need to be able to pick up to pass this exam. So we left this purposefully to the end so that it would hopefully remain in your memory banks for the next couple of weeks. Same with anatomy. Anatomy comprises about 2% of the information that comes up on the OITEs, but we all know based on how questions are designed that there is a lot more anatomy in the exam than is explicitly tested. That's how they get those 2- and 3-step questions that I was speaking about at the Miller Review course and how that can come into play there. Rehab is an important consideration as well, and we will have the second half of the talk devoted to that. So without further ado, here's Matthew, and he's going to take over and go through the rehab part of things. Matt?
Okay, thank you very much. I appreciate the opportunity to help give this webinar. We'll move right into the first question. A 3-month-old is brought to clinic for evaluation for a right upper extremity abnormality which has been present since birth. Which of the following physical exam findings is associated with the best functional outcome? Obviously, what they're talking about in this question is an obstetric brachial plexus palsy and how to determine which patients are going to have a better outcome in the future. You need to know a few things. First, what are the poor prognostic indicators? One of the first poor prognostic indicator is evidence of a Horner syndrome. Horner syndrome is where you're going to have meiosis and ptosis of one eye with that same side of the forehead being dry. And you can remember that through the acronym MAPE. MAPE is meiosis, or the pupil is constricted, anhidrosis, or lack of sweating, ptosis, or a drooped eyelid, and then inophthalmos, where that eyeball will appear sunken into the orbit. What about some of the other poor prognostic indicators? Well, if you have C5 to C7 involvement, that's going to portray that you are not going to have elbow function and also no wrist function. So if you think about, as we put our hand out in space, to be able to use that hand to feed ourselves or take care of ourselves, you need to have both elbow function and wrist function. And so those patients aren't going to do as well. Obviously, patients that have total plexus involvement are not going to do well. And the other group that falls into that is supraclavicular versus the infraclaviculares. And the way to remember that is that the infraclavicular is essentially distal to the trunks, and so it's treated more like isolated nerve lesions, whereas supraclavicular involves things like the branches C3, 4, and 5 going to the phrenic nerve, etc. And then also remember that Erb's palsies or isolated C5, C6 on the scale tend to do much better. When you have a Klumpke palsy or a C8T1 palsy, those tend to do poorly long term. Remember also, return of biceps function is key. So it's a very good positive indicator of return of global return of function. So the best lesion to have is an isolated C5, C6 lesion that has the best prognosis, especially if they have early biceps return. So if we look at this question, what they're asking is what is going to be the best prognostic indicator? And what you have to choose is the patient's going to have absent shoulder abduction and external rotation with intact wrist and digit flexion and extension. What they're getting is that C5, C6 lesion. Looks like a majority of people answered that. The other one that people answered was loss of hand function with preserved shoulder function. Remember, that's what you're going to see with the Klumpke palsy, meaning that they are not going to have the intrinsics function of their hand, but will have preserved shoulder function. So those actually do poor long term. Which artery is identified as artery X in the illustration in figure A and the angiogram in figure B? Well, this requires just some basic knowledge. And first we need to remember that the brachial artery divides at the radial neck and divides into your radial artery and your ulnar artery. The major branch that comes off your radial artery is the radial recurrent, and then that radial artery continues on and runs on the pronator teres and continues to the wrist between your pronator teres and your FCR. The ulnar artery, however, has a few more important branches. It's got your anterior and posterior recurrent ulnars, and then it gives off the common interosseous. Well, that common interosseous then splits into your anterior and posterior interosseous and gives off several muscular branches. So if we look at this question they're asking, you can see it's distal to that common interosseous, and they're actually asking about the anterior interosseous artery. And it looks like a majority of people answered that question correctly. The proximal extent of the posterior approach, or the Thompson approach to the radius, involves what surgical interval? So this is from the latest edition of Miller Review. As we look at some of the approaches to the forearm, remember your Volar workhorse is your anterior Henry approach, and then dorsally you've got your posterior, your Thompson approach. That the interval is between your ECRB, which is innervated by the radial nerve, and your extensor digitorum communis, which is innervated by the PIN. So that PIN comes into play, especially when you talk about how the proximal extent is limited by where that PIN comes out of your supinator. So when you're performing this approach, you actually find the PIN, you dissect it back and find where it comes out of the supinator. But remember, the interval truly is between your ECRB and your EDC, so radial nerve and PIN. And that's what they're asking here. It looks like a majority of people answered that correctly, with a few people saying it's between the ECRL and the brachial radialis. Remember, it's a little bit further over from that, and it's between the EDC and the ECRB. So a 58-year-old female undergoes right elbow arthroscopy for loose body removal and debridement. During the case, the anterior capsule of the elbow is violated while the arthroscopic shaver is being used through the anterior lateral portal. A clinical photograph demonstrating the patient's postoperative physical exam deficits are shown in Figure A. Which structure labeled in Figure B has most likely been damaged? So this is one of those two-part questions where you need to recognize A, what's been damaged, and then be able to pick it out on this cartoon diagram. So let's review a little bit about elbow arthroscopy and what nerves are at risk. So when placing the portals, remember that with the proximal anterior lateral portal, the radial nerve and the posterior interosseous nerve are at risk. With the proximal anterior medial portal, the medial antebrachial cutaneous nerve is at risk. And then with the posterior medial gutter, superficial to the capsule is the ulnar nerve. Remember also that the radial nerve comes down just anterior to your capsule at the mid-capitellum. Specifically, that's where that radial nerve gives off the posterior interosseous nerve branch. And so what this question is asking is saying that essentially at mid-capitellum, a nerve has been damaged. So you know it's going to be part of the radial nerve. Now, is it the radial nerve or the posterior interosseous? Well, how do you differentiate between those two? Remember that the radial nerve functions with your wrist extensor, so your ECRL and your ECRB. The posterior interosseous extends your digits, your EDC, your extensor pollicis longus and brevis, and your extensor indicis proprius. So as you can see in the clinical picture, the patient is able to extend their wrist but cannot extend their fingers, so therefore the PIN is the nerve that was injured. Which was labeled there on the diagram. It looks like a majority of people answered that correctly, and the rest answered radial nerve, but obviously that's where we've got to make that differentiation. 47-year-old male punches through a glass window and suffers a deep laceration that severs his brachioradialis muscle at the mid-forearm. What nerve is most likely to be injured? And so this, again, is knowing some of your surface and functional anatomy. We know that in the mid-forearm, directly under the brachioradialis is going to be your radial nerve, and then your superficial branch, specifically your superficial branch of the radial nerve. Whenever we do surgical approaches where we have to retract on that brachioradialis, we know that the SBRN is at risk for having a palsy afterwards. So when we look at this question, what they are asking, the only answer that makes sense is the superficial branch of the radial nerve, which everyone was able to answer correctly. During recovery for a radial nerve palsy, what is the last muscle to demonstrate evidence of reinnervation? This is a question that comes up routinely on testing purposes, and it's the order of return of either radial nerve palsies or PIN nerve palsies. And I think it's important to remember some of the relationships between these. Number one, remember that the PIN obviously is a branch of the radial nerve, and so the most distally innervated is going to be the last to return. That makes sense. Well, the most distally innervated is the EIP. When they talk about return to function, that's going to be the last to return to function. When we're looking at some of the other return to functions, I think it's important to commit this list, at least the understanding of it, to memory, because they can ask, well, which is going to come first? Is your EDM going to come first versus your EPL or EPB? So remember, the last is going to be EIP. The first is going to be the supinator. In some textbooks, you'll see that ECRB or ECRL are listed, and that can be either the first, that's purely posterior interosseous, but more commonly it has dual innervation, or it will be listed under a radial nerve. So remember, the last one to return, the last muscle to demonstrate evidence of reinnervation is going to be your PIN, which goes to your EIP. A 4-year-old male falls from the monkey bars and sustains an extension-type supracondylar humerus fracture with a neurologic deficit. Which of the following muscles is most likely affected? So to understand this question, we've got to know a couple of basics that go into our PEDS. Extension versus flexion-type supracondylars. Which nerves are more commonly injured? The most common nerve injury with an extension-type supracondylar is the anterior interosseous nerve. A radial nerve or a PIN nerve palsy would be second. If you have a flexion-type supracondylar humerus fracture, the palsy that's commonly tested is an ulnar nerve palsy. Okay, so we've determined that this is an extension type. The most common nerve injured is the AIN. So now we need to know, what is the innervation of the anterior interosseous nerve? Clinically, we look at FPL and FDS to the index finger, right? But you've got to remember some of the other structures that the anterior interosseous innervates. Specifically, the last one that's listed on this diagram is the pronator quadratus, which is what they were looking for in this test question. So I think it's important to remember, be able to recognize AIN is the nerve that's injured, and then be able to go through that catalog in your mind of which muscles does AIN innervate. It looks like a majority, 3/4 of people were able to answer with the PQ being the correct answer. Looks like FCR, which would be, I guess that would be number 2. Actually pretty evenly mixed. EDC came in there, so again, that's going to be a PIN nerve injury. Remember, that's the second most common. AIN is the most common, and so that's the take home for this. Which of the following unipinnate muscles takes its origin on the radial side of the profundus tendon, inserts on the radiolateral band at the middle phalanx, and creates a force vector that is palmar to the joint of axis of the metacarpal phalangeal joint? So there's a lot of information in this question. What you have to realize is that they are testing lumbricals versus the interossei. Okay, so if we go back to our anatomy, and this is a diagram again out of the most recent Miller review, which shows that the first and second lumbricals are, as we work our way from radial to ulnar, the first and second are unipinnate, while the third and fourth are bipinnate. The lumbricals, they originate from your FDP tendons, and they insert on the radial lateral bands of the extensor mechanism. And if you think about the intrinsic positive hand, that is the function that your lumbricals help assist with. So they extend your interphalangeal joints, both proximally and distally, while helping flex the metacarpal phalangeal joint. They extend the PIP through their insertion on the lateral band, and then they indirectly extend the DIP because the contraction helps release the flexor pull on that DIP. Contrast that to the interossei muscles. Remember, the interossei muscles are going to help with abduction and adduction. The dorsals are going to help with your abduction. Your palmars are going to assist with your adduction. So in this question, if you talk about, you know that they're talking about one of the intrinsics of the hand based on the fact that it came from the FDP and inserted on the lateral band. Then they said that force vector passes volar to the palmar joint axis of the metacarpal phalangeal joint. Well, that's another saying that your force vector is going to help flex that metacarpal phalangeal joint. So which of the intrinsics helps flex? We know that's going to be a lumbrical. Which of the lumbricals is unipinnate? 1 and 2 are unipinnate, whereas 3 and 4 are bipinnate. So the answer to this question is the first lumbrical. It looks like people were mixed up a little bit between the first and the fourth. That was the most commonly missed answer. And remember that third and fourth lumbricals are bipinnate. When performing the llioinguinal approach, what lies between your external iliac vessels and the lateral muscle compartment? So the llioinguinal approach, again, is used for pelvis and acetabular fractures. There's 3 windows of that approach. And so after you isolate the external iliac vessels and the iliopsoas tendon, you're able to gain access to all 3 windows. That medial window is medial to the iliac vessels, and that gives you access to the pubic rami. You can get an indirect access to your anterior SI joint and iliac fossa. The middle window is between, between your external iliac vessels and the iliopsoas. And the way you dissect that is you have to go through what's called the iliopectineal fascia. That gives you access to the pelvic brim, your quadrilateral plate, and a portion of the superior pubic ramus. And then lateral to your iliopsoas and subsequently the iliopectineal fascia is the lateral window. And that again gives you access to your quadrilateral plate, SI joint, and iliac wing. So the question that they're asking here is what separates the vessels from that lateral muscle group, or the iliopsoas? And the answer is the iliopectineal fascia. If we look on this cross-sectional diagram here, we can see that some of the other questions that they were asking are the sartorius. We know the sartorius is farther lateral. The femoral nerve is farther lateral, and specifically that fascia runs underneath your external iliacs, and then wraps in between that and the lateral muscle group, or the iliopsoas. Okay, and so that was the question that they're asking. It looks like. Looks like, again, that a majority of people are able to get that, with a smattering of people choosing the femoral nerve and the lateral femoral cutaneous nerve. Remember, that comes off further laterally. The lateral femoral cutaneous nerve is going to be somewhere around the region in between your ASIS and down to about 1/3 of the way down. Some people say 2 centimeters. So again, that's going to be further lateral than the the middle window of that llioinguinal approach. What isolated acetabular fracture pattern would be most appropriately treated with the approach shown in Figure A? So the first thing you have to do is recognize which approach is this, okay? This is an extended iliofemoral approach. We know that we use a variety of different approaches to gain access to our acetabular and pelvic fractures. We use posterior approaches primarily for posterior structures or posterior displacement. We use an illioinguinal to gain access to the anterior, and this is an extended iliofemoral, which gives us access to both some of the posterior structures and the anterior structures. I think when you're looking at these, if you look at what a Kocher-Langenbach is used for, anything that involves purely a posterior wall or a posterior column, sometimes a transverse with the posterior wall, those are all best addressed through a posterior-only approach. Similarly, if you have an anterior wall or anterior column, or if you have an anterior column plus posterior hemitransverse, those can be done through an illioinguinal. If you have a both column, you need to use both the illioinguinal and the Kocher-Langenbach, or you can use the extended iliofemoral. One of the other good indications for an extended iliofemoral is the specific transtectile transverse fracture that has roof impaction, because you're able to access both sides that you would not be able to get access to with simply Kocher-Langenbach or an illioinguinal. And so that's the specific one that they are testing in this question, and one that comes up repeatedly. So one of the best fractures to take care of with an extended iliofemoral is that transtectile transverse fracture with an impacted roof. It looks like about 40% or so of the people got that. The other 48% or so actually answered anterior column with posterior hemitransverse. And if we look back, an illioinguinal is well suited to treat that type of fracture, even more so than extended iliofemoral. Which of the following structures does not exit the pelvis proximal to the anatomic landmark identified in Figure A? So first we need to recognize, well, what is that arrow pointing to? And that arrow is pointing to the ischial spine. There are only a few things that exit the pelvis proximal to that ischial spine. And this is a cross-sectional through the pelvis at mid-sacrum. And you can see I've got the green arrow pointing to where the ischial spine is. And excuse me, we'll go back here. And so what exits superior to that is going to be your obturator internus up here, which is shown here. A majority of things exit inferior. And we'll talk a little bit about this later in the webinar, but when we talk about what leaves superior or in the superior to the ischial spine, there's a few key relationships to remember. The first is being able to recognize that the piriformis is what is the key to being able to recognize which of those leaves. Specifically, When we look at the gluteal artery and nerve, the superior gluteal is named in relation to that piriformis. So inferior to your ischial spine, but superior to the piriformis, the superior gluteal artery and nerve lead. And we'll talk about POPS IQ and how to remember that coming up in a few questions. But what this question was asking specifically is superior to your ischial spine, what leaves, because that separates your greater from your lesser sciatic, and that is actually the obturator internus. The remainder of these all leave from the, leave distal to the anatomic landmark, leave distal to that, and we'll show that relationship and as they relate to the piriformis. Figure A is a cadaver specimen where a posterior approach to the hip has been performed after removal of part of the gluteus maximus. Which of the following choices correctly identify structures A, B, and C? And so this has to do with our posterior approach to the acetabulum or posterior approach to the hip. And you need to know a couple of things. First, of the posterior ligaments, the sacrotuberous ligament, and I'll draw it out here for you, the sacrotuberous ligament runs vertical to your ischial tuberosity, okay? Runs up and down. The sacrospinous runs horizontal and comes to the ischial spine. So you need to be able to identify sacrospinous versus sacrotuberous. And then remember also the piriformis. The piriformis is a very readily identifiable structure when you come in posteriorly. And remember its relation to the sciatic nerve. In a majority of people, the piriformis, when you're looking from posterior, essentially drapes over the sciatic nerve, and the sciatic nerve leads from just deep and just inferior to that. So as we look back at this picture, we can clearly identify our sciatic nerve, which is shown here. We can see our piriformis draped across it here. And so they're asking us for what is B, which is the piriformis, what is A, which is going to be your gluteus minimus tendon, and then what is C? And it looks like a majority of people answered, got split between sacrospinous and sacrotuberous. Well, we know that the piriformis essentially leaves beneath the ischial spine where your sacrospinous ligament would be, so this has to be the sacrotuberous ligament. Remember, that runs vertical from your ischial tuberosity up to the sacrum, whereas the sacrospinous runs horizontal, would be in this plane here, running to the from the sacrum that direction. So I think that's where people got mixed up on this question. The piriformis is pretty readily identifiable, especially with your sciatic nerve being dissected out there. A 55-year-old male is involved in a motor vehicle accident, sustains the fracture pattern seen in Figure A. Which of the following approaches would provide the best exposure for open reduction and internal fixation? So what you have to first recognize that this question is looking at an acetabular fracture that has involvement of your quadrilateral plate here, and that's seen in this area here. So now the next question is, well, which approach will get me access to the quadrilateral plate? Surgical, it can be a very surgical challenge to gain access, and so you can use either an illioinguinal, which we talked about before, where you work through that between that medial and lateral window, going back and forth to gain access to the quadrilateral space or quadrilateral plate. Alternatively, you can use a modified Stoppa approach, which allows you to avoid the use of that middle window, and essentially that involves minimal dissection of your inguinal canal, your femoral nerve, your external iliac vessels. If you can imagine, if you can take all that stuff lateral, as shown here in this article from JOS in 2011, essentially you're able to retract all those structures laterally and gain direct access to your quadrilateral plate, as opposed to having to work through two separate windows going back and forth between the neurovascular structures. And that's kind of how this approach came about and what it's best used for. So when you look at when we look at some of the commonly tested items, when they're asking about a Stoppa approach, commonly they're going to be asking about gaining access to that quadrilateral plate, especially with displacement. Again, that was the answer here. It looks like a majority of people answered that. The extended illiofemoral, it was second most common. Again, we don't use that to gain access to the quadrilateral plate, but we would use the medial and middle window of the middle and lateral window of the illioinguinal, which weren't choices for this question. Next is, following an uneventful medial approach to the hip, the iliopsoas tendon is released. Which of the following neurovascular structures is most at risk during release of the tendon? What this is looking at specifically is that medial approach to the hip, where we learn about essentially most commonly used in Ludloff approach for congenital hip dislocation. There's a few risks you need to know about. The risks include the anterior and posterior divisions of your obturator nerve, but those are usually clearly identifiable as you're going down between your adductor longus and your gracilis, draped over top of your magnus. So you can protect those. What specifically comes into play when you perform an iliopsoas tenotomy is the medial femoral circumflex artery. And essentially that is hidden. It's directly underneath as it wraps around. And we'll talk a question about this a little bit later in the webinar. But as that artery wraps around, it is draped right underneath your iliopsoas tendon, and it's a majority of the blood supply to the femoral head. So the medial femoral circumflex comes between your pectineus and iliopsoas. It then circles around and runs between your obturator externus and your adductor brevis, and then proceeds distally anterior to the quadratus femoris, where it's potentially at risk with the posterior approach to the hip. So it's specifically at risk with the psoas tenotomy with that medial approach for DDH. And this is why we look at some of the earlier studies that looked at the Ludloff approach, and they had a significant rate of AVN. It wasn't sure if it was because the hips had been out for so long in these congenitally dislocated hips. Most likely it's due to inadvertent damage to the medial femoral circumflex involved with performing a psoas tenotomy to therefore reduce the hip. Again, it looks like a majority, 3/4 of people were able to answer that correctly. Their obturator nerve is at risk with this. The rest of the people chose obturator nerve. Again, it is at risk with this, but it's not commonly injured, especially during that release of the tendon, because it's easily identifiable. Which of the following approaches for total hip arthroplasty is reported to have the lowest prosthetic dislocation rate? So remember, the answer to this question is the lateral approach to the hip, or the Hardinge approach. And let's talk a little bit about that. For that approach, there's no true internervous plane. You split the gluteus medius. Remember, you want to tag the gluteus medius so that you don't extend past 5 centimeters to protect your superior gluteal nerve. You then detach the gluteus minimus from insertion to gain access to your anterior capsule. There's been a couple of good studies that looked at dislocation rates among the various approaches, and they found that the lowest has been with a direct lateral approach. The first one was from Core in 2002. They showed it was just over 0.5% compared to nearly 3.25% with the posterior approach, and that was only improved to 2% when you repaired those posterior structures. Similar to 2% for an anterior approach, or 1.25% for transtrope. This was repeated in Core of 2006, where again the results were similar. They showed in a meta-analysis about 0.5% dislocation with a direct lateral versus with what they called improved techniques in this meta-analysis, still a 1% risk of dislocation with posterior. So if they're asking for what is the best in terms of dislocation rates, the best in terms of dislocation rates still to this day remains the lateral approach to the hip, or the Hardinge approach. Looks like about half the people got that right. The other half of people chose the anterior lateral. And again, as I quoted in this, and this is from the literature, that it was slightly higher in anterior lateral. So to this day, it still remains that the lateral approach has the lowest reported rates of prosthetic dislocations. The medial femoral circumflex artery and first perforating branch of the profunda femoris artery anastomose at which of the following locations? So we're talking about the MFCA again. We talked about this before. The MFCA is the primary blood supplier to the adult femoral head. It anastomoses with the first perforating branch of the profunda femoris just medial to your gluteus maximus insertion. I think this is a very difficult subject to kind of wrap your mind around, because it represents a 3-dimensional analysis, and we're always studying off of 2-dimensional pictures. But if you look at this lower, and I'll pull up an arrow here and show you, if you look at this lower picture, we know that as the MFCA comes off, we know it's at risk as it runs next to that lesser troch in the front, okay, and that's where we talked about earlier with the iliopsoas tenotomy. Well, then it comes around and it anastomoses in the back with this first perforator right here down, distal to the intertrochanteric line, and that's where the insertion of the gluteus maximus is. Sectioning of the gluteus maximus during a posterior approach can put both of these vessels and that anastomosis at risk, and so that's the question they're asking for here. If we look at again, so where does it anastomose? And again, it is medial to the gluteus maximus insertion. Looks like about 40% of people answered that right. A large group of people answered medial to the gluteus medius. Now remember, your gluteus medius attaches up near the greater trochanter, and so what's at risk there would be your retinacular vessels as you move posterior superior. But what they were asking specifically for is the first perforating branch of the profunda. That is further distal and posterior, distal to your intertrochanteric line, and that's why that's the answer. Where is the origin of the muscle that is located between the anterior acetabulum and the iliac vessels? Another one of these two-part questions, and I think it's best interpreted if you look at a cross-sectional diagram. So they're asking what is between the anterior acetabulum here, anterior acetabulum here, and your iliac vessels. Well, if we know from our approaches to the anterior approach to the hip in children, or from our hip arthroscopy work, we know that that iliopsoas essentially drapes right over the front of the acetabulum. So the first part is being able to answer the cross-sectional anatomy question, which is it's the iliopsoas, which lies between your vessels and the anterior acetabulum. Now, where does that come from? The psoas originates from the transverse processes of L1 through L5, and remember also that's how it helps cover your lumbar plexus when we look at some of our other anatomy questions. So the answer that we're looking for in this question is the lumbar transverse processes, because again they're talking about that psoas muscle and its origin. Looks like a majority, 3/4 of people were able to answer this correctly. The second place answer was anterior inferior iliac spine, so that would be your rectus femoris, which is going to be a little bit further distal and is not in between the anterior acetabulum and the iliac vessels. What two nerves make up the internervous plane in the Smith-Petersen anterior hip approach? Well, the anterior approach, the Smith-Petersen approach, the superficial dissection is between your sartorius and your TFL. Your sartorius is innervated by your femoral nerve, your tensor fasciae lata innervated by your superior gluteal nerve. The deeper dissection is between your rectus femoris and your gluteus medius. The rectus femoris, again, your femoral nerve, and the gluteus medius is your superior gluteal nerve. So the internervous plane for this is the femoral nerve and the superior gluteal nerve. It looks like almost 90% of people were able to get that answer correctly. A 67-year-old male with severe hip arthritis presents for evaluation of a total hip arthroplasty. He's requesting a minimally invasive Watson-Jones approach, as he has heard postoperatively the mobility is significantly improved compared to a traditional transgluteal technique. What should the patient be told to expect regarding early postoperative gait kinematics when comparing these surgical approaches? So let's review a little bit about the anterolateral or the Watson-Jones approach. For this one, there is no true internervous plane. You do develop an interval between your tensor fasciae lata and your gluteus medius. Remember from the previous questions, those are both supplied by the superior gluteal nerve. Traditionally, the anterior 1/3 of your gluteus medius and the entire minimus is then detached. The minimally invasive, or what this patient is requesting, doesn't take down the glutes, and so there's a potential perceived benefit of less dissection with the theoretic improved outcomes. However, there's been a couple of studies, including a recent review in JBJS of 2010 that looked at groups, 20 patients in both groups, and showed that there was no difference in their gait kinematics at 3 months. So although it does provide with less dissection, maybe a smaller scar, there hasn't been a study that's proved inferior gait kinematics with the traditional approach versus the MIS as of yet. And so that's the answer that they're looking for. There is no difference in early gait kinematics between the two approaches. It looks like a majority of people were able to get that correctly, 68%. The next most common was answer 4, which is the traditional transgluteal approach results in worse early gait kinematics. And as we showed in that 2010 JBJS study, that has not been proven to be the case as of yet. Patient is undergoing percutaneous iliosacral screw fixation for a sacroiliac joint diastasis. The proposed screw trajectory into the S1 body is represented by the red star on the drawing of the sacrum in figure A. What is the most strength deficit sequelae of the proposed screw trajectory? What they're showing here is with this red star, they're saying essentially you're going to violate the anterior aspect of the sacrum. So if you were going to pick a path that allows you to come out the anterior aspect of your sacrum, A, what's at risk? B, what are you going to pick up on your physical exam? So another one of these two-part questions. We know that the L5 nerve root exits the foramen and essentially is draped across the anterior aspect of the sacrum. So that will come up in a testing scenario. The L5 is the nerve root that is at risk if you have anterior violation of your sacrum. So the next step of that is, well, what does the L5 nerve root do? What does it do? And we know that it involves the extensor digitorum longus or EHL, and that's how it's going to be tested. And that's what they're looking for here, extension of the great toe, which 95%, almost everybody was able to get correct. Injury to the deep perineal nerve, which would result in which of the following? Remember that the deep perineal, sometimes known as the anterior tibial nerve, it runs along the anterior surface of the interosseous membrane and supplies the musculature of the anterior compartment, shown here, the tibialis anterior, your EHL, your extensor digitorum longus, which are shown on this MRI. Remember also that the deep perineal supplies your peroneus tertius, which is found more distal, and it gives sensation to the first web space. So the answer, if someone has an injury to the deep perineal, is going to be weakness of great toe extension, which almost everybody was able to get correctly. During total hip arthroplasty via a posterior approach, where is the sciatic nerve most likely to be found? Again, we talked a little bit about this on one of our earlier questions, but remember that in a majority of patients, the sciatic nerve exits inferior to the piriformis and courses posterior, or if you're looking from the back, essentially superficial to your short external rotators. So remember, it comes out from deep to the piriformis and then courses superficial or anterior to the piriformis and posterior to your short external rotators. There was a study in clinical anatomy in 2010 that showed there was some slight variation in sciatic nerve anatomy, but 88% of people, so nearly 90% of people have that prototypical. In some situations, it'll split the piriformis, or you'll have a split sciatic nerve. But I think it's important to remember that essentially the sciatic nerve is going to be draped over top of your short external rotators and is going to be coming out of the piriformis, usually at its inferior extent. And so again, that's the answer here, and it looks like 80% of people were able to answer that correctly, with the second most common being answer 2, which is superficial to the piriformis and deep. And remember, that's just flip-flopped. And so it's important to remember superficial, we're talking about a posterior approach, and so as you go through, it is going to be deep to the piriformis, even though it's a more anterior structure. The inferior and superior gluteal nerves are designated as such based on the relationship to what structure. This is what we were talking about earlier. So when we talk about the nerves leaving the pelvis, the piriformis is the key to the greater sciatic foramen. What I mean is that the superior gluteal artery and nerve exits superior to that piriformis, whereas almost everything else leaves inferior. How do you remember what leaves inferior is up to you, but I think one of the easiest ones is POPS IQ. So as we move from lateral to medial, as they exit inferior, you get your pudendal nerve, your nerve to your obturator internus, your posterior femoral cutaneous nerve, your sciatic nerve, the inferior gluteal nerve, and then the nerve to the quadratus femoris. So remember, we're talking about the greater sciatic foramen. The superior gluteal artery and nerve leaves superior to your piriformis, which is shown here. Again, it's a very recognizable structure when you're in this region of the body, whereas most everything else leaves here inferior to that. Looks like about 75% of people were able to answer that correctly, with a smattering of choices, the most common being the sacrospinous. And so again, just remember, it's not in relation to the sacrospinous ligament, because the superior gluteal artery nerve actually leave inferior to that sacrospinous ligament. But they are superior to the piriformis. That's what puts them in the greater sciatic foramen, is being inferior to that sacrospinous ligament. Which of the following muscles originates from the ventral surface of the sacrum? So this is, I think it's a difficult question, because they're giving you a list of muscles and asking you to remember where the origins of all of them are. But if you think of some key relationships, I think you can help answer some of these questions. When we look at obturator internus and obturator externus, we know that those are going to come off, originate around the obturator foramen. Hence, that's why it's in their name. The quadratus femoris is one of the short external rotators, and that is going to be coming off essentially off of the ischial turossian, inserting over in your intertroch region. The piriformis, we'll get to in a minute, but then the other one is the superior gemelli, which again is going to be coming from right around the area of the obturator foramen. And the piriformis is coming, you can see it, its origin is here, is on the ventral surface of the sacrum. So by process of elimination, you can answer this question. But I think it's important to, when you look at these, where the origin insertions, to be able to pick out some key things. The piriformis is essentially the only structure that comes off that side of the sacrum, so that would make it a very testable item. Again, when we talked about the psoas originating on your transverse process of L1 through L5, that's unique. That could potentially be a testable question, like they're asking here. So it looks like about 2/3 of people are able to get that correctly, and I think we showed in that previous diagram why the other answers are wrong. The most commonly was shown was the obturator internus. Remember that the origin of that obturator internus is going to be right around the obturator foramen. Which of the following nerves innervates the short head of the biceps? The biceps is one of those muscles that has a short head and a long head, and it receives innervation from two separate parts of the sciatic nerve. Remember that the short head is innervated by the peroneal division, while the long head is innervated by the tibial division. And the way I remember that is PS and LT, lieutenant LT. So PS, peroneal, short head, LT, long head, tibial division. Looks like a majority, 3/4 of people were able to answer that, with the other people getting mixed up between the peroneal and tibial divisions. So remember, PS, peroneal division, innervates your short head. LT is the long head, innervated by the tibial portion. The axial MRI shown in figure A shows a tumor located in one of the muscles of the thigh. Which nerve innervates the muscle? So again, this is another one of those two-part questions where first you've got to be able to identify through your cross-sectional anatomy which muscle are they asking about, and then be able to identify which nerve innervates that. So when we talk about the proximal thigh, there's a couple of things that I want you to remember, and I think the easiest way to remember where you're at is the sartorius and the gracilis. The sartorius is always an anterior structure, and remember that the gracilis, as we move from proximal to distal, becomes more of a medial structure as it acts as we travel distally. So depending on where we get that cross section in the thigh, you'll always be able to pick out your sartorius, and then you should be able to pick out the gracilis as it moves from an anterior to a medial structure. Remember, these muscles in cross section have very similar shapes. They're a little bit narrow than the more bulky adductor longus that sits underneath them. So if we look back at the question that they're asking us, you can see here, let me show you, that we have two structures very similar. One's obviously more anterior and one's more medial. Well, if we know based on just the sartorius and gracilis, we know that this has to be the sartorius, whereas the gracilis is always going to be more medial. And as we move further distal in the thigh, that gracilis will essentially be in cross section, seem like it's wrapping around further medial and medial. So then the next part of that question was, well, what innervates the sartorius? And that answer is the femoral nerve, which it looks like about half people were able to get correct, with number 3 being the other most common, being the obturator. So being confused, being the sartorius, being confused with one of the adductor groups. And so I think that's where the confusion comes from. Remember that sartorius is always going to be the most anterior structures when we look at that versus the gracilis, which is more medial. Hunter's canal is bordered by what two muscular components? Hunter's canal runs deep to the sartorius. Okay, we just talked about that sartorius, and it runs between your anterior compartment and your medial or your adductor compartment. So when we start off up, and I think that if you think about it in a sense that the femoral vessels are, they come off anteriorly, all right, underneath the inguinal ligament, and then Hunter's canal is essentially, as you move more distally, the medial compartment maintains its relationship to those vessels, meaning it stays posterior to those vessels. Even though the vessels themselves course to a more posterior direction, they still stay in front. They don't pierce through the adductors until they get down to the canal. So that's why it's between the anterior compartment, your knee extensors, and then your medial compartment, which is the adductors. And it looks like, again, a majority of people are able to answer that correctly. The second most common being the medial and posterior compartments. And just remember that the medial compartment is always going to be posterior to those vessels. So they have to be between the medial and the anterior. During a total knee arthroplasty using a standard medial parapatellar approach, if a lateral release is required, special attention should be made to preserve which of the following arteries? We know that the medial parapatellar approach essentially violates all of the medial blood supply to the patella. If you combine that in the sense of doing a total knee, when you resect the fat pad for visualization, when you resect the meniscus, that leaves essentially only the superior lateral genicular artery as the only remaining blood supply to the patella. So you need to be cautious with your lateral release to specifically try and save that superior lateral genicular artery, because as we mentioned, as you take out everything else, specifically in the setting of a total knee arthroplasty, that's going to be the only remaining blood supply to the patella. And so that's the answer there. It looks like, you know, almost 90% of people are able to answer that correctly. What is the internervous plane for the posterior lateral approach to the tibial shaft? Well, the posterior lateral approach, the interval is between your soleus and your FHL, and that involves the tibial nerve, and then between your perineals, which are the superior perineal nerve. So you detach the FHL from its origin on the fibula, you detach the tib post from its origin on the interosseous membrane to reach the tibia. What's at risk is the neurovascular structures of that posterior compartment. What you can see here is in red, I've got the anterior tibial artery, obviously in the anterior compartment. You have your perineal nerve and artery and vein, excuse me, which are just posterior and just medial to your fibula. And then in between your superficial and your deep posterior compartments is where you have your posterior tib artery and vein. So the neurovascular structures at risk specifically are all those of the posterior compartment, but you have to pay special attention to the perineal artery. So what you're doing is you are taking off the FHL from its origin, and we've got the lateral compartment there. So as you can see here, you take the FHL off its origin, then you use that to protect your perineal artery and vein. You take the posterior tib off its origin, off the interosseous membrane, and that gives you access to the posterior lateral aspect of the tibia. Remember also, another question that comes up in relation to this is the relationship between your FDL, your posterior tib, and your FHL. Remember, your FDL is going to be on the more tibial side, with that posterior tib muscle being midline or essentially coming off your interosseous membrane, and the FHL is the most lateral. So the answer again was between your tibial and superficial perineal nerves, which nearly 90% of people were able to get correct. A 34-year-old male sustains a traumatic injury to his foot following a motorcycle accident. The patient's neurovascular status necessitates the amputation demonstrated in figures A through C. 1 year following the amputation, the patient complains of difficulty with gait and deformity of the ankle. Which of the following statements best describes the forces resulting from this deformity? I think you need to take a minute to look at the actual films here and realize what's missing essentially. So if we look at this, the patient's essentially lost all of his forefoot and even in some of the midfoot. If you look, there is no fifth metatarsal, there's no base of the fifth metatarsal. So with that would be your peroneus brevis insertion. They've lost a majority of the middle cuneiform, and also the entire first metatarsal. And so we know that the anterior tibialis inserts on both the medial cuneiform and the anterior tib. And so what this patient is going to have is unopposed pull of the gastroc and the tib posterior, because they've lost the attachment side of their tib anterior, but also it's my mistake it's not on this slide, but they've also lost the insertion of your peroneus brevis and your longus, because that longus, remember, it wraps around the plantar aspect of the foot and inserts back onto the first metatarsal. So if you have no peroneus longus and you have no tibialis anterior, you're going to have unopposed pull of the gastroc and the tib posterior. So you're going to go into an equinus contracture with hindfoot varus. And so what they're asking for in the question here is you can see on that middle radiograph that they have an equinus contraction. You can get an idea based on that semi-oblique on the far right that they have some hindfoot varus as well. So the answer is unopposed pull of your gastroc soleus and your posterior tib. So now I think Derek's going to come in and do some of the spine anatomy questions. I'll turn off my mic here.
So Matthew, thank you. That was excellent. Great job there. We really appreciate it. So I'm going to do 3 spine questions, and then we're going to hang it over to Frank. So first question. A surgeon is planning to place an anterior interbody device in the lumbar spine using a retroperitoneal approach. A vertebral body is identified directly posterior to the bifurcation of the aorta. What is the most likely level of the vertebral body? So to get this question right, you need to be familiar with the retroperitoneal or the anterolateral approach to the lumbar spine. So to do this approach, you place the patient at a 45-degree angle on the table, and then you make a fairly long oblique incision over the iliac crest. Let me get the arrow up. So you make a long incision here, and then you do your approach. You go through the abdominal muscles, the external oblique, internal oblique, and transversus muscle. And then you find this plane, and this is a great illustration by Hoppenfield, where you find the plane between the retroperitoneal fat, which is indicated by this yellow stuff here, and the peritoneal cavity. Once you find this plane, you can actually retract the peritoneal cavity medially. Make sure you bring the ureter with it. And once you do that, you're going to see the anterior surface of the psoas. And once you see the anterior surface of the psoas, it's easy. You just follow that up anteriorly, and then you're going to see the anterior surface of those vertebral bodies. Now, to get this question right, you need to understand where the bifurcation of the aorta is relative to the vertebral bodies. So this is a picture of an angiogram. You can see the catheters coming up inside the aorta, and I've basically illustrated where L4 and L5 are. So here you have L4, and here you have L5, and this clearly shows that the bifurcation of the aorta sits directly anterior to the vertebral body of L4. So when you're doing this approach, you're usually doing it to do either a fusion at L4-5, a fusion at L5-S1, or a total disc replacement at one of these, or some type of anterior corpectomy with decompression. So if you're working at the L4-5 disc space, what you do is you ligate the segmental arteries, and then you actually pull the great vessels over to the side. So you come in from the side and you pull by mobilizing the great vessels. This is very different if you're working at the L5-S1 disc space, which is way down here, well below the bifurcation. And this time you jump over the common carotid and work between the common carotids, below the bifurcation. So going back to the question again, they're asking, you're doing an anterior approach to the lumbar spine. What is the most likely level of the vertebral body directly behind the bifurcation of the aorta? And based on this illustration, you can see that is clearly L4. 69% of you got that correct. It looks like the other people, 11% and 12%, were basically saying L2 and L3, which are further up. So next question, you have a 53-year-old female who has 8 hours status post the procedure seen in figure A. You are called to the room by the nurse who reports the patient is having difficulty breathing. On arrival, you notice that the patient has stridor on inspiration and a firm mass under the incision. What is the most likely cause of a respiratory compromise? So looking at this x-ray here, you can see she had an anterior corpectomy. Whenever you're looking at levels here, you just identify the ring of C1 here. This is the tip of C2. C2 is easy to identify. So here you have C3. So she had a C4 corpectomy. So to get this question right, just a quick review. You got to be familiar with the anterior approach to the cervical spine. It's a very easy approach. You can just stick your finger up here and you can actually feel the approach, and you can push down on the spine. I always do this to localize the plane before I do my dissection. If you pull your fingers medially, you can see it changes your voice. And that's because medially you have the tracheoesophageal bundle. If you pull laterally, you can feel the muscle of the sternocleidomastoid. And if you rotate your head, you can feel that sternocleidomastoid. And if you feel under that, you can feel your carotid pulse. So you just have to remember that the carotid vessels, as you can see here, sit right under the sternocleidomastoid. When you do this approach, what you're trying to do is get down, get through your prevertebral fascia, and then identify your two longest coli muscles, which are here. And you want to do all your work between the longest coli muscles. This is your safe zone. You can think of them as the goalposts you want to work between. So the situation in this question is you have a patient who had anterior surgery and now she's having respiratory compromise. So there's several different causes of respiratory compromise after anterior cervical surgery. The most common one is edema. However, the most dangerous one is a hematoma. And basically what happens is after you close the platysma, blood can accumulate with enough pressure to close the trachea and the airway. The key thing to differentiate these two, especially for testing purposes, is if it's a hematoma and you do an exam, you're going to see a mass and you're going to be able to feel a firm mass. If you see that in a real situation, it's a surgical emergency or emergency, you need to decompress that mass to protect their airway. There's two ways to do it. Some people say do a needle aspiration. I think it's better just to get a sterile kit, open up the incision, and then just take a few stitches out from your platysmal closure and decompress that hematoma. So going back to the question, again, you had a 53-year-old female who has 8 hours status post-corpectomy. She has respiratory compromise and stridor. On exam, here you have the key word. She has a firm mass under the incision, and this is really what you want to look for. What is the most likely cause? And because she has that firm mass, you're thinking hematoma, which is answer 2. 94% of you got that right, so good job. So last spine question, which of the following items is located medial to the iliocostalis and lateral to the semispinalis muscle? So to get this right, you basically need to know the muscular structures in the posterior lumbar spine. And this illustration basically shows the 4 muscles that you need to be familiar with. Most medially superficial is semispinalis. Actually medial to that, but deep, is the multifidus muscle. So just lateral to semispinalis is longissimus muscle. And even further lateral to that is iliocostalis. You can see these same muscles in this cross section. Again, most lateral is iliocostalis, medial to that is longissimus, and medial to that is your multifidus, and more superficial, your semispinalis muscle. So going back to the question, they're asking which of the following items is located medial to the iliocostalis muscle. So here's iliocostalis, so we're looking medial to that, and lateral to semispinalis muscle, which is here. So that's going to put you right in the middle, which is the longissimus muscle. So the proper answer is 3. 75% of you got that right. You know, a lot of you chose multifidus. Multifidus is actually medial and deep to the semispinalis muscle. So at that time, we're going to hand it over to Frank. Frank, why don't you go ahead and turn on your, don't forget to turn on your microphone and then turn on your webcam.
That won't work. Here we go. Alrighty, so let's get going with the next slide. So when we look at rehab and prosthetics, we have about 18 questions amongst the group that we're going to be looking on. So the rank is number 4, which is fairly high in terms of what's asked for where we're going. So a 27-year-old patient comes in for a prescription for his below knee amputation prosthesis because it's not fitting properly. All of the following are complaints and examination findings consistent with a prosthetic foot that is placed too far inset, except. So here we're looking for the wrong answer, meaning that 4 out of the 5 are the correct answer. Now if we look at prosthetic alignment, if the foot is insert, and if one looks at the right hand diagram, then the lateral is to your left and medial is to your right, and the foot is then inset from the midline. And the way to try and remember this is it's like having a varus knee, so that the stresses are going to be proximal medial and distal lateral, exactly as you would see somebody who has varus knees or is bow-legged. And associated with this is a turning out of the foot. The exact opposite occurs when we have an outset of the foot. Again, lateral is to one's left and medial is to one's right, and from the midline of the socket, the foot is outset. And so the exact opposite occurs in terms of pressures, and the way to try and remember this is as if one has a valgus knee or is knock-kneed. And so pressure is medial distal, as one sees on the diagram, and proximal lateral is where pressure is almost at the knee joint, and in this situation at the head of the fibula. So back to the question, the wrong answer is number 3, increased knee extension during stance phase, which is the only one that doesn't occur. All the others are correct. Now, if one looks at the answers, only about 50% of test takers got that one right. And number 4, the socket pain is located lateral and distal, which is actually different, which you would see with the inset foot rather than the outset foot. A 44-year-old male with transtibial amputation is interested in doing more hiking as a hobby. However, he's had difficulty negotiating uneven terrain with a solid ankle cushioned heel, the satch foot. Which of the following modifications to the new prosthesis would be most appropriate? If we look at prosthetic feet, the current standard for today is to use some form of articulated or flexible dynamic foot, of which one sees 3 examples in this illustration. And most of them end up having some form of associated ankle motion, and the top one and the bottom right both show the articulated ankle plus a shock absorber that one sees at the back of the bottom illustration. Now, common to most of these is the split toe. One sees that in the left-hand diagram or the left-hand illustration, as well as the bottom right hand. Now, all these prostheses are useful for uneven terrain and for high activity, but the key here is the split keel for the uneven terrain. So the preferred response to the question was the sagittal split articulated dynamic response foot number 4, and the majority of you got that answer correct. A 36-year-old woman with a transtibial prosthesis is seen to have knee buckling, that is, drop-off, during terminal stance, meaning that the knee is giving out while the individual is coming into the end of stance phase. What prosthetic modification would correct this problem? In other words, how do we stop the knee from buckling? So if we look at the prosthetic foot, if the heel is too soft, the knee will remain in extension. And the way to try and remember this one is if you're walking on the beach through soft sand away from the waterline. So the foot tends to keep going, or the heel tends to keep going into the sand. And the same thing with a soft heel. It's absorbing the force, so it's not allowing the knee to bend, so the knee stays in extension. Now the opposite, if the heel is too hard, that's the same as walking right at the water's edge on the hard, firm beach surface, and so the knee will tend to flex prematurely. Now if the foot is plantar flexed, the knee will stay in extension. It's like an equinus deformity, as you would see either in a stroke patient or a post-polio patient. And if it's dorsiflexed too much, then there's drop-off, and the knee will bend or flex prematurely. Now, associated with that is if the prosthetic foot is either too far forward or too far posterior. And the right-hand illustration, on the left-hand diagram, the foot is set more posteriorly, as with the midline designated between anterior and posterior, and the right-hand diagram shows the foot set to anteriorly. So to answer your question, the preferred response was you want to move the foot slightly more anterior because it's been too far posterior. Now, some of you answered that question to move the foot more posterior, and the reason yes, you are moving it a little bit from its anterior position. However, you don't want to set it more posteriorly because then you run into the problem of premature or staying in extension. Which of the following amputations has the least increase in metabolic demand for walking compared to patients without amputation? And if we look at the bar diagram at energy expenditure, we note that energy expenditure is inverse to limb length, so the longer the limb length, the less the energy expenditure, and it's measured with oxygen consumption. And one looks at the middle bar, which is about an increase of 25% above average for level walking gait in an individual. So the preferred response, which the majority of you got correct, was number 1, traumatic amputations. The problem with vascular amputations is that they do not have the physical reserve for most of their gait. A 45-year-old patient with a below-knee amputation is interested in hiking as a hobby. He would like to know more about his satch foot before selecting a different terminal device. As we remember from the previous slide, the satch foot is the solid ankle cushioned heel, which is not a dynamic response foot. In other words, it has no energy storing. So if we look at what the different type of feet again are, the dynamic feet are the flexible keels where they will deform under load, as you see in the top illustration. The bottom illustration is a cross-section of a satch foot. Now, the elastic keels are for the most part made of carbon fiber or polypropylene, and the problem with satch feet is that they can lead to gait abnormalities because of their inflexibility and potential overload. So if we look at the correct answer, number 3, the longer duration mid-stance of gait, because remember, this is not correct. All the other 4 are the correct answers. So only about half of you got that answer correct, and then it was split between 1 and 2 in terms of less frequent replacement, which is sort of correct, but with the carbon fiber feet, that's not. They are fairly durable. And number 4, increased ground reaction force does not apply to the satch foot in this situation. A prosthetic foot which incorporates a multi-axis articulated foot assembly is recommended for which of the following amputees? Now here again we see 2 different types of prosthetic feet. The multi-axial foot in the top illustration, and the dynamic running leg, which is also a type of C foot, which has a large amount of flexibility and therefore spring, which makes it easier for the athlete to run, especially in the transtibial, but also for some of the transfemoral. Now, individuals who use both these type of feet for variation in gait, in terrain, or for running, would use a standard dynamic foot for most of their regular activities. So the correct response for this answer, which most of you got right, was number 4, for the individual who wants to walk on uneven ground. A 49-year-old diabetic veteran undergoes transtibial amputation. What is the most important factor to determine the best lower limb prosthesis for this patient? Now remember, he's diabetic and he probably has other comorbidities. So if we look at prosthetic prescription, these are not dependent on the age or gender of the patient or the etiology. So the type of prosthesis is predicated on the type of predicted function that these individuals would have. And in this situation, number 3, current and potential functional level was the correct answer, which the majority of you were able to get correct. A 45-year-old diabetic woman with a gangrenous foot undergoes a Chopard amputation without tendon transfer or lengthening. Which type of deformity is most likely the complication of this procedure? Now, if you remember back to the anatomy lecture just a few minutes ago, there was a picture of a foot with a Lisfranc type amputation. This one had a more distal amputation. Now, if we look at midfoot amputations, the key to all of these procedures is Achilles tendon lengthening, and if necessary, a tibialis tendon transfer either to the cuneiforms or to the navicular or even the neck of the talus, depending on whether it's a Lisfranc amputation or a Chopard amputation, because for transmetatarsals, one does not necessarily have to transfer the tibialis anterior. And so here we have a similar illustration showing a Lisfranc type amputation in the upper radiograph and the right-hand illustration. And one can see that there is callosity at the area here where rollover would take place. Now, in the bottom picture is an individual that's had a Lisfranc amputation, but also a tendo-Achilles transfer and a tibialis anterior lengthening, and is able to keep that foot out of equinus and even slight varus. So the correct response to this answer was number 3, the equinus deformity, which most of you were able to get correct. In consideration of a prosthetic knee, each of the following prosthetic knees are advantages of choosing a polycentric knee with fluid control over constant friction knee, except. So now if we look at the prosthetic knees, the polycentric instant center of rotation changes with flexion, and flexion occurs at about 15 degrees as noted in the right hand diagram, and the left hand picture is an illustration of a polycentric type knee, which is similar to a 4-bar linkage. Now the key here is the red line illustrates part of the body's weight, which is anterior to the point of rotation, therefore helping to keep the knee extended with weight bearing and allow for flexion when one's in swing phase. So the correct response is number 3, lighter in weight. All of the following are advantages of a body-controlled prosthesis compared to myoelectric prosthesis for patients with upper extremity amputations, with the exception of prosthetic use occurs in 70% of patients fitted within 30 days of amputation. Transradial amputation, about 70 to 80% of amputees will use a prosthesis. Now, the myoelectric prosthesis tends to be used more for sedentary work, and the body powered is activated by biscapular abduction. Also remember that voluntary opening hooks, shoulder abduction and flexion open the hook. We use a step-up hinge for short transradial amputations, and for elbow mechanisms, shoulder extension and depression. Now, the harness of the ring is at C7 on the intact or non-amputated side. So the correct response to this question was a decreased amount of harnessing with the myoelectric prosthesis, which the majority of you were able to get correct. A 34-year-old male is an inpatient at a rehabilitation facility after sustaining severe lower extremity injuries in a motor vehicle collision. As a result, his energy expenditure while ambulating is 40% above baseline after being fitted with an appropriate prosthetic prescription. What is the patient's most likely lower extremity amputation? And again, back to the bar graph, 40% is for short transtibials or for bilateral transtibial amputees who will still have a better energy expenditure than a unilateral transfemoral amputee. So the correct response for this one, which most of you again got correct, was a bilateral transtibial. The unilateral average transtibial, which some of you in answer number 2 remember, is only about 25% above energy expenditure. For an above-knee amputation, each of the following is a benefit of adductor myodesis except. So we're looking for the wrong answer again amongst those 5 options. The muscle does the surgery stabilizes the muscle and does provide soft tissue padding at the end and helps maintain the mechanical and shaft axis of the extremity. It also allows for prosthetic fitting. So the incorrect answer here is that it allows for preservation of greater femoral length. That is not correct, and most of you got that answer correct. Patients with transradial amputations are considered the best candidates for a myoelectric prosthesis. Each of the following have advantages compared to a body-controlled device, with the exception of. Now, if we look at the myoelectric prosthesis, it is heavier. It does require fewer suspensory components. It is not for laborers because they can damage the mechanism. It does allow for overhead work, and it does require more training because the patient has to learn how to fire the muscles that are going to fire the electrodes that will move the hand. So the correct answer for this one was number 3. None of these prostheses, whether they be myoelectric or body powered, have any kind of sensory feedback. Now, some of you answered number 1, provide more proximal function. That is not correct as far as this particular question is concerned. A prosthetic polycentric knee with hydraulic swing control is chosen for a very active 63-year-old transfemoral amputee. All of the following appropriately describe the features of this prosthesis, except, again, we're looking for the wrong answer. Now, knee disarticulation in dysvascular patients allows for easier transfer. Prosthetic user has direct load transfer, and polycentric knee provides stability. Again, we go back to that diagram showing the polycentric knee with flexion occurring at about 15 degrees and the body weight being anterior to the knee to provide stability and keep the knee in extension. So the correct answer here was number 4, which all of you, or the majority of you, got correct. The knee center of rotation is fixed anterior to the line of weight bearing, so that is the incorrect answer, because otherwise flexion would occur and the knee would be unstable. Now, in this question, the pattern of ambulation showing with an assisted device in video A is most appropriately described as which of the following. Now, if we look at the use of crutches, they require an increased energy expenditure of between 32 and 42%, and paraplegics who use a swing-through gait, and I'll highlight that in a moment, go up to 42%, but they have to use orthoses with this. Remember also that paraplegics are prone to carpal tunnel syndrome and rotator cuff tears because of their wheelchair use. Now, to highlight the difference between swing-to gait and swing-through gait, remember that in swing-to gait, one bears all the weight through both crutches, and we swing the legs forward at the same time up to the crutches, but not past the crutches. Whereas in a swing-through gait, again, bearing all the weight through both crutches, meaning the upper extremities are taking the load, the legs are swung forward at the same time, but past the crutches, in other words, to some point in front of the crutches. So that's the difference between swing-through gait and swing-to gait. So the correct answer for this one was number 1, swing-to gait, and as I've just highlighted, number 3 was not the correct answer, which again nearly 40% of you gave. Now here's another crutch question. A 34-year-old female undergoes open reduction and internal fixation for the left lower extremity injury shown in figures A through C. Postoperative weight-bearing protocol includes toe-touch weight-bearing to the left lower extremity. Which of the following ambulatory support devices is most appropriate for this individual? Now, the top illustration shows weight-bearing in different stances, but only using one particular assistive aid on one side. And so it's the first diagram A shows weight-bearing on one leg, and then bipedal stance, and then stance with a cane or a quadrilateral cane. The bottom picture shows what happens if one uses a cane in the opposite hand to reduce the joint force across the hip or the knee. And the reason for doing that is the lengthened lever arm from the cane to the joint. So if we look at walking aids, bilateral crutch use allows for offloading of the affected limb. Single walking aid will only help unload the opposite hip or knee, the joint space, not the actual limb itself. So the correct response for this one, which a majority of you got right, was number 1. A 52-year-old man has difficulty walking 3 months after undergoing successful transmetatarsal amputation for ischemic gangrene. Observation of his gait reveals a shortened stance phase and abrupt abbreviated toe-off on the surgical side. Which of the following devices would most likely improve his gait? So if we look at what we see here, transmetatarsal amputations are done in selected patients, sometimes for trauma, sometimes for vascular disease, as you see in the bottom right-hand illustration. Remember again, Achilles tendon lengthening for all of them, and most of these individuals will ambulate with appropriate shoe modification. And the shoe modification that we talk about is a rigid steel plate or a shank and a rocker sole to allow for rollover at the level of the amputation. So the correct answer for this one was number 5, which most of you were able to get correct. I think we are at the end of our slideshow.